Okay. Good morning. As part of our series of lectures from recent advances in surgery, today we have selected the topic of neck dissection in head and neck cancer. So, Dr. Saurabh Ghosh, who is professor and head of surgical oncology at Medical College Kolkata, will deliver this lecture on neck dissection. So, Saurabh is a very avid oncosurgeon, and he does a lot of neck dissection. So, he will put in some his personal notes also into the lecture. So, Dr. Ghosh, you can start.
Thank you, sir, for the kind words. Good morning, everyone. So, the topic for today is neck dissections. So, cervical lymph node metastasis are the single most important prognostic factor in head and neck squamous carcinomas, by which we generally mean the carcinomas involving the oral cavity, oropharynx, larynx, or hypopharynx, things like that. So, once these cancers spread to the neck and involve the neck nodes, the cure rates of these cancers drop by almost 40 to 50% in those patients for the same T stage. For the same T stage in the oral cavity, if it is N0, then the chance of the patient being cured is almost 40 to 50% more than the patient who has also got neck nodes for the same T stage. So neck dissection is an operation that has been designed to remove all the lymph nodes in the neck, that is on one side of the neck, normally in the midline, along with the fibrofatty tissue in the neck and certain non-lymphatic structures also, certain blood vessels, certain nerves, which are not strictly part of the lymphatic operation, but I'll come to that, why we used to remove them in the past and why we don't remove them always nowadays. So what are the indications for neck dissection? So neck dissection is a part of the surgical treatment of most head and neck squamous carcinomas. Sometimes these cancers are also treated by radiation, in which case we may not be doing a neck dissection. But if we are treating the primary tumor with surgery, then almost invariably we will also include some kind of a neck dissection as a part of the treatment. And these sites are mainly the oral cavity and the hypopharynx and the larynx. These are the most important sites for which you need to do a neck dissection. Sometimes for oropharyngeal cancers, you may also need to do a neck dissection. By and large, oropharyngeal cancers are not treated by surgery. By oropharynx, I mean base of the tongue, the tonsil, the soft palate. Malignancies of these sites are normally treated by radiation. And so the radiation field also includes the neck. But if there is a very bulky cervical lymph node associated with these cancers, then they will not respond to radiotherapy. So you may also have to do a neck dissection to remove the lymph nodes in oropharyngeal cancers. And the same with nasopharyngeal cancer. Nasopharyngeal cancers tend to have cervical lymph node metastasis, but they are generally sensitive to chemoradiation. And the neck is also treated along with the primary by the radiation field with chemotherapy. But if there is a large nodal disease or there is a residual nodal disease after treating with chemoradiation, then you might have to do a neck dissection even for oropharyngeal or nasopharyngeal cancers. So for both clinical node positive and node negative patients also, we need to do a surgery for the neck node. What kind of surgery? We'll come to. It's different. A surgery of the neck for the neck node positive and a surgery of the neck for a node negative patient is not the same. It is slightly different. And the basis for this, that we have to do surgery for a clinical node negative comes from a trial which was held in Tata Memorial Hospital, Mumbai, called the N0 trial. Other head neck malignancies like differentiated thyroid cancers or medullary cancer of the thyroid gland, even rarely anaplastic cancers if they are operable, they also tend to spread to the cervical lymph nodes, and we may have to do a neck dissection for a part of the treatment of these cancers also, surgical treatment. Then we have got salivary gland cancers like malignancies of the parotid gland, of the submandibular gland. So sometimes minor salivary glands have cancers, and these cancers spread to the neck nodes primarily. So then to treat them surgically also you have to do a neck dissection. Similarly, there are skin malignancies of the head and neck region like malignant melanomas and squamous carcinomas. Malignant melanomas especially tend to have lymph nodal metastasis, and part of a treatment you might have to do a neck dissection along with removal of the skin primary. The nodes that are removed are not always the same. So the lymph nodes that we will remove for a papillary thyroid cancer are not the same as the lymph nodes that we will remove for a carcinoma, squamous carcinoma of the buccal mucosa. So the various groups of nodes that are excised during surgery depend on the primary site and also the extent of the nodal involvement. So what are the factors which influence the chance of having nodal metastasis. So generally it is seen that if this is mainly for the oral cavity, we are discussing the oral cavity now. If the site is more anterior, then the chances of lymph nodal metastasis is less. So if it is a carcinoma of the lip or the lower alveolus anteriorly or the upper alveolus anteriorly, then the chance of having is cervical lymph node metastasis is less compared to if the cancer is arising from the tongue or the posterior part of the buccal mucosa or the RMT. Then if a younger patient has got oral cancer, then the chances of lymph nodal metastasis are more because younger people tend to have more aggressive cancers. If the T stage is higher, the chances of metastasis are greater. That is obviously true for almost all cancer in the body. As the T stage progresses, chances of lymph node metastasis increases. If you find that there is lymphovascular emboli or perineural invasion of the primary, then again there are greater chances of metastasis to the cervical lymph nodes. And a higher tumor grade also correlates with a greater chance of metastasis. So these are all the clinical and some of the histological factors of the tumor which will influence the risk of developing lymph nodal metastasis. So just a brief word of the anatomy of the neck. The neck is conventionally divided into an anterior triangle and the posterior triangle. Anterior triangle is further divided into submental, submandibular, carotid, and the muscular triangle. And the posterior triangle is divided into the subclavian triangle below and the occipital triangle above. So this is just a diagram which shows you. So submental triangle is bounded. It's a erect triangle with the base formed by the hyoid bone, the apex formed by the mentum, and the two sides, the two anterolateral sides formed by the anterior belly of the digastric. The submandibular triangle is formed by the lower border of the mandible. It is an inverted triangle. The apex is below. This is the junction of the digastric with the hyoid bone, which is the apex. The base is formed by the lower border of the mandible, and the anterior and the posterior borders are formed by the anterior and posterior bellies of the digastric muscle. Then we have got the carotid triangle, which is formed superiorly by the anterior superiorly by the posterior belly of digastric, anterior inferiorly by the superior belly of the omohyoid, and posteriorly by the anterior border of the sternomastoid muscle. This contains mainly the vessels, the carotid vessels, and you've got the muscular triangle below it, which are covered by the strap muscles. Similarly, the posterior triangle has got the subclavian triangle below, where you can get the subclavian vessels, and the suboccipital triangle or the occipital triangle above. These are not very important from the clinical point of view. This is how the classical anatomy was described, so I've just included a slide in there. We are more interested in the levels of lymph nodes. Cervical lymph nodes, nowadays, for the purpose of surgery, are divided into groups or levels. Instead of saying the submental group or the jugulo-digastric group or the jugulo-omohyoid group, we generally call them level 1 to 5. And level 1 is further divided into level 1A and level 1B. Level 1A are the submental group of lymph nodes. Level 1B are the submandibular group of lymph nodes, which are above the hyoid bone. 2, 3, and 4 are the upper 1/3, middle 1/3, and the lower 1/3 of the nodes along the sternocleidomastoid, below the sternocleidomastoid muscle, which are mainly along the internal jugular vein. So for the radiological purpose, upper third is decided by the base, above by the base of the skull, and below by the hyoid bone. So any lymph node which is between the base of the skull and the hyoid is level 2. Level 3 is from the hyoid up to the upper border of the cricoid cartilage, and level 4 is from the cricoid cartilage up to the clavicle. And level 5 is the entire posterior triangle, which is bounded anteriorly by the sternomastoid muscle, posteriorly by the trapezius, and below by the middle third of the clavicle. So all the lymph nodes in the posterior triangle are considered level 5. These are mainly distributed along the course of the spinal accessory nerve. And in addition to that, you've also got level 6 and level 7. Level 6 are the central compartment lymph nodes. I'll come to that. And level 7 are the superior mediastinal lymph nodes above the innominate vein. So what are the types of neck dissection? So the original neck dissection that was propagated by Cryle in the year 1906, so more than 100 years ago, was radical neck dissection. And we still do radical neck dissection sometimes, occasionally when the need is seen. But mostly we do something which is known as a modified radical neck dissection, where we remove the lymph nodes from the levels 1 to 5. So in the radical neck dissection also, we used to remove the lymph nodes from level 1 to 5 on one side of the midline. And in modified radical dissection also, we remove all the lymph node groups from level 1 to level 5. So what is the difference between a radical and a modified radical neck dissection? I'll come to that. Then you have got selective neck dissection, where not all 5 groups or all 5 levels are removed. So when you are removing all levels from 1 to 5, it is a modified radical neck dissection. If you are not removing levels 1 to 5, then you do a selective neck dissection. And very rarely you might have to do an extended radical neck dissection, where you remove either the superior mediastinal lymph node or you remove the posterior neck nodes like the suboccipital nodes and all. Those are very rarely done now. Now, the selective lymph node dissections may further be the supraomohyoid neck dissection, which is from level 1 to 3, most commonly done for an N0 oral cavity. A lateral neck dissection, which is level 2 to 4, this is generally done for hypopharyngeal or laryngeal cancer. Then you need to do an anterolateral neck dissection or sometimes a posterolateral neck dissection. And for thyroid, parathyroid malignancies, we sometimes do a central compartment clearance, which is just the removal of the level 6. So just one slide for the central compartment, because that is not classically a part of neck dissection. Central compartment extends from the hyoid bone above to the innominate vein below, and on both sides the lateral limits are formed by the carotid sheath. So one carotid to the other laterally. So basically it is the center of the neck. It is covered by the strap muscles anteriorly, and level wise this is level 6 or part of level 7, and anatomically these are the pretracheal and the paratracheal lymph nodes, the paraesophageal lymph. These are important mainly for differentiated thyroid cancers, medullary thyroid cancers, rarely parathyroid malignancies. If we are treating, then we may have to do a central compartment clearance on that side, and also for laryngeal cancers. The complications that may occur for doing central compartment clearance are mainly recurrent laryngeal nerve injury and parathyroid devascularization. So these are the main complications, other than usual surgical complications like bleeding or injury to those structures which are there. So that is all about central compartment. We will not be discussing anything more about central compartment clearance. So now we come to the difference between RND and modified radical neck dissection. I said in both cases, we remove level 1 to 5 lymph nodes on one side of the neck. So then what is the difference? In radical neck dissection, all the lymphatic structures from the lower border of mandible to the clavicle and from the lateral border of the strap muscles to the anterior border of the trapezius are removed. So level 1 to level 5. But in addition to that, some non-lymphatic structures like the spinal accessory nerve, the internal jugular vein, and the sternomastoid are also removed routinely in radical neck dissection. The submandibular salivary gland on that side is also removed. Part of the lower pole of the parotid gland, which extends below the lower border of the mandible, is also removed. But gradually, as surgery evolved and people started to critically evaluate their results, many workers found that in many cases, the routine removal of these non-lymphatic structures like the spinal accessory nerve or the internal jugular vein did not really help in the cure rates. And so they proposed that these need not be removed in all cases. So they started preserving these non-lymphatic structures, and that kind of operation came to be known as a modified radical neck dissection. So what are the structures which are preserved in modified radical neck dissection? So there are 3 types of modified radical neck dissection. A type 1, in which the spinal accessory nerve is preserved. The spinal accessory nerve supplies the trapezius muscle, also the sternocleidomastoid. The sternocleidomastoid is not so important, but the trapezius is very, very important for shoulder function. So if you routinely sacrifice the spinal accessory nerve, post-operatively, the patient tends to develop a lot of shoulder dysfunction, movement, stiffness, the shoulder droop, there is chronic pain. So if you can preserve the spinal accessory nerve, then these things don't happen, and there is no difference in cure. In a type 2 modified radical neck dissection, the spinal accessory nerve and the internal jugular vein both are preserved. And in the type 3 MRND, the spinal accessory, the internal jugular vein, and the sternomastoid muscle, all 3 structures are preserved. So 1 structure preserved in type 1, spinal accessory, 2 structures preserved in type 2, spinal accessory and internal jugular, and 3 structures preserved in type 3, spinal accessory, internal jugular vein, and sternomastoid muscle. So now we continue with the difference between radical and modified radical neck dissection. The original radical neck dissection was designed for an en bloc excision along with the primary. So they would almost always remove the mandible, and in those days it was known as a commando operation, combined mandible and oral, COM-MAND-O. But nowadays it has been seen that the mandible is not always involved in an oral cancer, say, which is involving the buccal mucosa or the tongue. And the lymphatics also do not always go along the periosteum of the mandible, though that was the thought which prompted them to remove the mandible en bloc. So nowadays the mandible is not routinely involved, and hence though these non-lymphatic structures are also not involved. although the lymph nodes in the neck are distributed along it. So the lymph nodes in the neck at the level 2, 3, 4 are distributed along the internal jugular vein. And so the older workers used to think that the lymphatic channels would be traveling along the vein, and excising the vein would help us to remove the lymphatic channel. So this was somewhat like a Halstedian concept of breast cancer, remove everything in continuity. But nowadays we know that the spread of cancer through lymphatics is not like an army marching through. It is more like terrorist attacks. One discrete event of a tumor bolus going from the tumor into the neck. So just by removing routinely all the lymphatic channels, you cannot stop it, because that may already have occurred. So the evidence for this, that routine sacrifice of the internal jugular vein or the spinal accessory nerve did not improve cure rates, was provided first by a gentleman called Boca, who has done a lot of work in the neck. In the series of about 800 plus patients, they compared modified radical neck dissection to radical neck dissection in oral cancers, and they showed that modified radical neck dissection was as effective as radical neck dissection in controlling metastatic disease. You need not sacrifice the spinal accessory nerve or the internal jugular vein routinely just because the lymph nodes are arranged along there. So nowadays, modified radical neck dissection is a standard of care operation for a person of oral cancer who has got positive neck nodes of say N1 or N2. But if there is an N3 node, which is a large node, more than 6 centimeters in size, then probably you still have to do a radical neck dissection, because the nodes are so large, they would be probably infiltrating the internal jugular vein and the spinal accessory nerve, and you will have to sacrifice them. Now we come to the N0 neck. Suppose there is, when we talk about N0, we are talking about clinico-radiological N0. So we have got a patient of oral cancer. We are examining the neck and we find that we cannot palpate any lymph node. We get a CT scan done, or we get an ultrasound of the neck done. Suppose there's a papillary thyroid cancer, and we find that there is no abnormal enlarged lymph node in the neck, even on ultrasound or a CT scan. Such a patient would be called a clinico-radiological N0. However, studies have shown that even in these clinico-radiological N0 patients, almost 30% of them will have occult micrometastasis. We do not have any technology to detect these 30% who have micrometastasis. So previously, we used to do surgery for all of them. And so in many cases, in 70% of cases, we were over-treating them, because in 70% of cases, the clinico-radiological N0 would actually come out to be pathological N0. And there is obviously no benefit to removing a true N0 neck node. So we are giving these patients the morbidity of a neck dissection while we are not giving them any benefit. So when I was a student doing my MCH in surgical oncology, there was always a controversy. So there is a very small oral primary, T1 lesion of the oral cavity, and there is no palpable cervical lymph nodes. Whether we should observe the neck or whether we should remove the neck, there was no evidence for that. And so especially in very early primaries, for a T1 lesion, where the chance of the occult metastasis was say less than 20%. The incidence of 30% is for all T stages, from T1 to T4. But for a very early T1 lesion, the incidence is not 30%. The incidence is maybe 5% or 7%. So routinely removal of the lymph node was criticized, and it was discussed about that what are we doing, why are we giving morbidity of a neck dissection to the patient just for the chance of a 5% or a 7% risk of occult metastasis. Is it really proving beneficial to the patient? So then came the N0 trial, which was done by Tata Memorial Hospital to settle this question of whether it is advantageous to do a neck dissection in a clinico-radiological N0 neck with a small primary. So it was published in NEJM in the year 2015. It is a landmark trial. You should know about this. 500 patients of oral squamous cancers, T1 or T2, so small cancer. If it was a large T lesion, so it's a T3 or a T4 lesion, even if it is N0, most surgeons would operate in those. There is no controversy because the chance of occult lymph node metastasis is very high. But for an early T1 lesion, whether there is any benefit to doing a neck dissection, they studied this. So these patients were randomized to upfront surgery of the neck versus watchful waiting and surgery only if metastasis occur. So by this, they hope to avoid surgery in the patients who were truly node negative. And they would only operate the neck if the patient presented with neck dissection. So, and then they followed up these both the groups of patients, the one group which had elective neck dissection in spite of being node negative, and the other group which had therapeutic neck dissection only when the nodes became positive on follow-up. And it was seen that in the elective surgery arm, there were only 50 deaths, whereas there were 79 deaths in the therapeutic surgery arm at follow-up. So the hazard ratio of death at 3 years was 0.64 with a 95% confidence interval 0.45 to 0.92. So that is on one side of unity. So this is a statistically significant difference. So the chance of dying was, the relative risk of dying in the arm who underwent an elective operation was 36% less than the group who did not undergo neck dissection and who were kept on follow-up and who were only offered a neck dissection when they presented with neck node. So it was seen that upfront surgery was beneficial. So nowadays, the conclusion is that all patients of oral cancer, even if it is clinico-radiological N0 and even if there is a very small primary, they need some form of neck dissection. Possibly the only exception to that, if you see the NCCN guideline, they will say, so a T1 lesion of the lower lip with a clinico-radiological N0, you may not do a neck dissection electively. And in those cases, probably you need to do a sentinel node evaluation for a N0 neck. But for oral cavity, sentinel node dissection is still experimental. It's not standard of care. It is somewhat difficult to do because oral cavity has got a lot of cross communication in the neck, and especially midline lesion, and injection into the primary and following them in the neck is not easy because there is a wide range of lymphatics. So to find out one area where you can make a small incision and detect the lymph node is not easy, especially if you're using the blue dye. And the radionuclide is not always available in all centers. So sentinel lymph node dissection for oral cancer is still not the standard of care. There is not enough evidence for that. So what are the imaging that you do for cervical lymph node, for evaluating the cervical lymph node? So most commonly we will do an ultrasound with a guided FNAC if some node is found to be enlarged. And you know the routine, we have had classes also earlier where we have said what are the ultrasound features of an abnormal lymph node in the neck. So normal lymph nodes are generally oval, whereas metastatic lymph nodes are more rounded. They tend to lose the fatty hilum, their resistive index changes, and there is increased vascularity, which may be peripheral and heterogeneous vascularity. And all these are features. And finally, the proof is by doing an FNAC of that suspicious node and proving cytologically that it contains metastasis. If you are doing a CT scan for evaluation of the primary lesion, then obviously you will do a CT scan of the neck along with it. In one investigation, you will settle it. Rarely you might need to do an MRI for a very bulky lymph node where you are assessing resectability and you want to see the involvement of the carotid vessels. You may need to do an MRI, contrast MRI. A PET CT scan is sometimes done. The typical indication for a PET CT scan is for a occult primary with cervical lymph node, where you are not finding any obvious primary, but there is a neck swelling and you find that the neck swelling contains a malignancy, which is a squamous carcinoma. So in that case, we do a PET scan to detect the occult, and we also use that to detect any occult nodes there may be present. So the PET scan combined with the CT scan has got the highest negative predictive value, that is to say whether a cervical lymph node is positive or negative. So now we come to the actual neck dissection. What are the incisions that are used? So there is no ideal incision for doing a neck dissection. Each incision has some advantages and some disadvantages. So the choice of incision depends to a large extent on what is the primary tumor that has to be removed. So when I am doing an operation for an oral cancer and I need to do a neck dissection, and in another patient, I am doing an operation for a laryngeal cancer, I want to do a laryngectomy, and I want to do a neck dissection along with it, the incisions will differ. Although maybe the neck dissection that I'm doing may not be so different. I may be removing the level 2, 3, 4, and 5 in both cases, but the incision will be different. So for oral cavity, which is the most common indication for neck dissection for our surgical practice, we generally use something which is known as the modified Schrodinger's incision. So modified Schrodinger's incision gives us an excellent exposure. I will show you the incision, but it has got a 3-point junction. And you know from your basic surgical training that a 3-point junction anywhere in the body, the healing is poor. So a T cut, T incision, or a modified Schrodinger, which is somewhat like a T, the healing of the 3-point junction is somewhat difficult. So that is the only drawback. Otherwise, Schrodinger's is a good incision that gives good exposure and it is easy to develop. So this is the Schrodinger's incision. So the modification that we make is we make this upper transverse neck incision from the mentum, starting from the mentum and going up to the tip of the mastoid. And it is around 1.5 inch or 3 centimeters below the lower border of the mandible and parallel to it. And from its middle, we drop a vertical incision, which is to the mid-clavicular point, And here the starting point is slightly below the carotid pulsation, so that the 3-point junction is not over the carotid vessel. So upper transverse neck incision extending from the mentum up to the tip of the mastoid, and a vertical drop down from that, which is going to the mid-clavicular point. And this vertical drop down is not a straight line, we know, because it is a flexor surface of the neck. You don't make a vertical incision over the flexor surface, otherwise that will lead to contracture. So you generally curve it like this diagram shows, or you can make a S-shaped incision. So some of the other incisions that are used are the H incision. This also gives an excellent exposure, but as the flaps are not very large, but you can see there are 2 3-point junctions, so that is a problem. In a post-radiotherapy, very often there is a scenario where the primary has been treated with radiotherapy, the neck has also been treated with radiotherapy, the primary has responded totally. There is no evidence of the primary cancer anymore, but the neck nodes still persist after radiation. In that case, you have to do a salvage neck dissection. And since the skin is already irradiated, the healing is poor. So in these patients, we generally use a McPhee's incision. A McPhee incision is very useful. The vascularity is very well preserved. So you make 2 parallel transverse incisions in the neck. One is below the mandible, 1 inch below the mandible, one is 1 inch above the clavicle, and you lift the upper part of the skin above, you lift the lower part of the skin below, and in this bridge of skin, you may tunnel it, and then you fold it, and someone has to retract it. So the exposure is not very good because someone has to constantly retract this bridge of the skin in the middle, and you have to dissect under the skin to remove the lymph nodes, which can be quite difficult. The access is not as good, but the vascularity of the skin flaps is preserved very well. So wound healing is better in McPhee's incision. So then there is a Conley's incision, there is a double Y incision, then there is an apron incision. This is the Gluck Sorensen's apron incision, which is generally used for cancers of the larynx, the hypopharynx. So if we are doing a pyriform sinus cancer where we are doing a laryngopharyngectomy and we want to do bilateral neck dissection, we use the apron incision. This is known as a half apron or the J-shaped or the hockey stick incision or the utility incision. This is an incision which is most commonly used for an unknown primary with neck node metastasis. Sometimes there is just a large level 2 or 3 neck node, but there is no obvious primary in the oral cavity or in the oropharynx or in the larynx. So then you just need to do a neck dissection. And for that, generally, this incision is used. It is cosmetically good and it also gives a good exposure. So what are the preoperative preparations that you need to do for doing a neck dissection? So obviously, you need to shave the face and the neck, remove the hair, because especially the oral cancers are more common in males, and males tend to have beards, so that can be difficult. For the oral primary, you start mouth washes. Obviously, the patient is kept nil orally overnight for around 4 hours fasting or 6 hours fasting. If you are going to do an operation for the oral cavity or the hypopharynx or the larynx, then you need to put in a nasogastric tube. Just for the neck dissection, you don't need a nasogastric tube. You need to put a nasal intubation again because the oral cavity needs to be operated. So oral tube will not allow you to operate in the oral cavity. So it has to be a nasotracheal intubation. And generally, we like to keep the blood pressure below 100 millimeter of mercury systolic because the neck is a very, very vascular area. There is a lot of oozing and bleeding unless the BP is kept low. So what are the operative steps? Generally, the head end is kept elevated like any operation for head and neck. The head end is kept elevated. The neck is extended and the head is turned to the other side. The neck is extended by keeping a sandbag below the shoulder. The face and the neck is draped with a 3-towel technique. And the incision is made and infiltrated with adrenaline, 1 in 1 lakh. So that allows you to make the incision without too much of oozing. Otherwise, the skin of the neck is very vascular and there is a lot of oozing. So once you've made the incision, whichever incision you are using, suppose you are using the modified Schrodinger's incision, then you subplatysmally the skin flaps are raised. So the level of the dissection is below the platysma because the blood supply to the skin is mainly from the subdermal plexus, and the plexus are just between the skin and the platysma. So if you stay below the level of the platysma, you will not damage the subdermal plexus supplying the skin, and skin flap necrosis will be less. And all the lymph nodes and the fibrofatty tissue from level 1 to level 5 are removed from the underlying pretracheal fascia and the floor, the muscles of the floor of the posterior triangle. That is the levator scapulis, splenius capitalis, scalenus medius, and the scalenus anterior. The submandibular gland is also removed, which is in the submandibular triangle. You have to ligate the facial artery and the facial vein twice above at the upper border of the gland and the lower border of the gland to clear the level 1B nodes along with the submandibular gland. Then you go along the posterior belly of the digastric and you lift it up and you expose the internal jugular vein and the spinal accessory nerve, and you dissect them out. Then you dissect out the entire spinal accessory nerve up to its entry into the trapezius muscle, clear the entire posterior triangle of the fatty tissue above the plane of the pretracheal fascia, preserving the phrenic nerve and the brachial plexus spots. Then finally, you dissect the nodes of the internal jugular vein. You remove the fascia of the carotid sheath, because sometimes the lymphatics travel along this facial sheath. So you remove the facial sheath of the internal jugular vein, and any final attachments are removed, divided, and the specimen is removed. Then we achieve hemostasis. Before putting in the drain, we always ask the anesthesiologist to keep the blood pressure back up, because you remember we started operating with the hypertensive anesthesia, keeping the BP below 100 millimeter of systolic. So now, before closing, you should always ensure that the BP is back up to normal, so that you can check any bleeding that might be there. You achieve hemostasis and you put in suction drains normally, and then you close the wound in 2 layers. One layer is the platysma and the second layer is the skin. So those are the operative steps. What are the complications of neck dissection? Complications may be divided into early and late complications. So I don't have the operative video. So complications are: early is you may have hemorrhage, which may be primary or reactionary hemorrhage. Primary hemorrhage is the hemorrhage that occurs during the operation. You know, there are so many vascular structures that can be injured. You can injure the internal jugular vein. You can injure the facial artery, the common facial vein. You can injure the submental vessel. Then in the lower neck, you have the transverse cervical vessels and their ascending branches. So all these vessels can be injured. There are several important nerves in the neck which can be injured. The spinal accessory nerve is the most important. I have highlighted it because in a radical neck dissection, we excise it. But in a modified radical neck dissection, we try to preserve it. So we have to dissect it out. But in the process, sometimes we may accidentally injure it. Then there is the phrenic nerve that can be injured. The marginal mandibular nerve, mandibular branch of the facial nerve, is in close relationship with the lower border of the mandible. So while dissecting the level 1B nodes, you may injure the marginal mandibular nerve. While doing the posterior triangle, if you are not careful to stay above the pretracheal fascia level, you may injure the brachial plexus also. On the left side of the neck, the thoracic duct enters the junction of the internal jugular vein and the subclavian vein. So the thoracic duct may be injured on the left side, and that is also a very problematic complication. So always when you're doing a neck dissection on the left side, at the end of the procedure, you should check for injury of the thoracic duct. Sometimes it is not very apparent intraoperative, and you have to make a special effort to check it to see if there is any watery discharge in the lower neck after lowering the head and doing a Valsalva maneuver. And if you detect it intraop, then you have to carefully take bites and ligate the thoracic duct. But sometimes it is not detected intraoperatively, and you can only detect it postoperatively, and then it becomes a problem because it leads to a chylous fistula. The chylous fistula is a very, very problematic complication. So you may need to re-explore and ligate it. If you have not maintained the proper plane and you have raised, or your incision is badly planned, then the skin flap edge gets necrosed. That is also a problem. So you have to keep doing dressing. Sometimes you need to put in a skin graft. If it is a large area of necrosis, then sometimes a flap has to be done to cover the wound because underlying vessels are exposed, and that can be a dreaded complication. So you have to be very careful in designing your flap incision and raising the skin flap. You have to use a cautery at a low setting. Sometimes because we excise the lower part of the parotid gland, sometimes the parotid fistula develops or a seroma develops in the neck, and that has to be aspirated repeatedly. Obviously, if there is a reactionary hemorrhage and the drain gets blocked, then there is a hematoma in the neck. So again, we may have to explore the neck and remove the hematoma, achieve hemostasis, give a wash, and close the wound again if there is a reactionary hemorrhage and the hematoma is detected in the post-op period. And obviously, any wound, there may be infection, but by and large, infection is not a very common problem of head and neck cancers because the vascularity is excellent, and these are clean operations by and large, or clean contaminated operations. So these are the classical complications of just a neck dissection. If we are combining a neck dissection with the excision of a primary also, then obviously there are certain complications involved with or associated with the removal of the primary tumor. That they are strictly not complications of the neck dissection, so I have not touched them, like orocutaneous fistulas and all, which were present in the neck, but they are the problem of the primary, not the neck. And there are some delayed complications also, like secondary hemorrhage can occur due to infection, due to flap necrosis and secondary infection. Because of this, the wound may get exposed and the underlying carotid artery or the internal jugular vein may be totally exposed, and they may get eroded by the infective process. And then suddenly there may be a massive hemorrhage in the ward that is known as a carotid blowout. And generally that is a fatal condition. If at all you are there in the ward, when the doctors are there in the ward and the patient can immediately be shifted to the OT, then the carotid artery has to be ligated. But even that has got almost a 30 to 50% incidence of a stroke, because the carotid artery generally has to be ligated, the common carotid artery. You cannot repair it because it is so sloughed and infected that a repair is generally not possible. If you have got a vascular surgeon on standby and they can come immediately and they can replace the infected part with a graft, then it is fine. But generally in an emergency setting, that is not possible. And the carotid artery on that side has to be ligated, which leads to an incidence of cerebrovascular accident or stroke, unless the opposite carotid is very well maintained and the circle of Willis is well maintained. But the incidence of CVA is almost 30 to 50% after a carotid blowout, where you have to ligate it. And if you cannot ligate it, obviously the patient will bleed to death. Then, as I said, if you remove the spinal accessory nerve and you remove the sternomastoid muscle and you remove all the lymph nodes, so there is a lot of fibrosis after that, and the trapezius muscle has some atrophy, and that leads to shoulder dysfunction. The patient is unable to raise his arm, and there is also chronic pain, neck stiffness and pain. That is a very, very common complaint of patients who undergo neck dissection. Then sometimes there is a lymphocele or a seroma which forms. After the drain is removed, there is persistent lymphatic ooze and a collection forms in the neck, which is a lymphocele. You generally have to repeatedly aspirate it and it settles down. And obviously there is a cosmetic deformity. If the sternomastoid muscle is removed on that side, then that side of the neck is a little hollow as compared to the opposite side. There is a big scar in the neck. Sometimes the scars undergo keloidal changes. And overall, it is not a good cosmetic. So that brings me to the end of my presentation. I would be happy to take any questions.
It's a very comprehensive description of the neck section. So you can answer any question you face during examination. So you can describe the steps, indications, everything is covered. So any question Dr. Ghosh will answer. Any question from the participants? Saurabh, if you have a situation that you are doing a thyroid malignancy and you have lateral node dissection being involved, in that case, dissection will be from 2 to 6. You spare one.
We will spare one. Thyroid cancers generally don't go to level 1A or 1B, so we don't need to do level 1A or 1B. So we need to do the central compartment and we need to do the level 2 to 5 on that side. 6, obviously, central compartment is coming in separately. So sometimes if it's a papillary CA and there's just one node in the lateral neck, I would not even maybe do 5. You would do a 2 to 4. But if you are very radical, you might do 2 to 5. But in a medullary cancer, yes, 2 to 5 on that side if there is no problem.
So as you define MRND, in MRND you are not including that 6 is there. In thyroid also you say you are doing MRND.
No, in thyroid we would call it a selective neck dissection. So central compartment clearance, level 6 we would term separately as a central compartment clearance, and level 2 to 4 we would be a lateral neck dissection, or if you are doing a 2 to 5, then you do a posterolateral neck dissection. So I would say I am doing a total thyroidectomy, a central compartment clearance, and a left level 2 to 5 or a left posterolateral neck dissection. That is how I would describe it.
Okay. So if there is no other question, you can conclude today. Thank you very much, Dr. Ghosh, for the comprehensive description.
Thank you.
Thank you very much.
Thank you, sir.
Thank you.